Thank you very much for coming. Thank you for having me here. It's a real privilege to talk to you. I've never used one of these mics before. I'm going to try and decide if I'm going to be a rock star or a stand-up comedian, or maybe you can decide. Fiona gave me a very kind introduction. I was thinking, who's that woman? I wish I knew her. I'm very much a jobbing geriatrician, and I face a lot of the same dilemmas from a slightly different perspective that you do. I certainly see people on many, many medicines, and my favourite question to ask them is, do you rattle? And it's amazing how many say yes, really. I try and practice evidence-based medicine, but I am human and I have some disclaimers. I have experience-based medicine. Experience tells me tramadol is bad. I have an opinion, and my opinion is that Zopiclone is evil. I sometimes practice volume-based medicine if I have to. I don't like it, but occasionally I will shout. And occasional obscenity-based medicine. I do swear. As Billy Connolly says, sometimes there isn't an alternative. I don't pretend to have all the right answers, like all my colleagues have said before me. I just do the best I can, as we all do. I've yet to meet a doctor who gets up in the morning and thinks, whose life can I screw up today? Now, where do I point it? There. Oh, no, I've given away the answer. Damn. This is my, I know. Oh, you may notice you haven't got my slides. I deliberately asked that you not get them before, but you can have them after. But this is a ramble, really. It's a discussion, as the title says. We may not get through all my cases. You may have other more interesting cases that you want to interject with. And thank you to the few of you who emailed some questions. I deliberately didn't go away and try and look up the answers because I thought we should keep it real. Well, I've given it away, but this is one of my favourite quotes. I can teach you how to bottle fame, brew glory, and even put a stopper in death. And if anyone doesn't know who said that, be ashamed. The very late and great, gorgeous Alan Rickman, portraying Professor Severus Snape. And he said this to Harry: I can't do any of those things. I don't have a magic wand, I'm not a witch, I'm not a wizard, and I certainly can't put a stopper in death. And increasingly in my job, as I deal with the frail and complex older people who are often coming towards the end of their life, whether or not they may have realised it yet, I increasingly believe that my job is to try and give people a good quality of life for however long they've got, not necessarily to prolong their life at all cost. When asked, and this is retrospective, when asked when it's pretty obvious that they're near the end of their lives, people often say that they would rather have not had a number of hospital admissions or invasive investigations or procedures. And the key one here is they wish they hadn't been taking pills that weren't actually making them feel better. And this is very challenging because, as you've heard before, how do we know when that end of life starts? But, you know, evidence does suggest that people use the most healthcare in the last couple of years of their life. So if people's attendance at your surgery or at hospital or at the pharmacy is escalating, it might be a bit of a clue. Marion spoke very clearly of the importance of prognosis, and work needs to be done on this. We are better at predicting the lifespan of fridges than we are of each other. And if you look on the internet, and I have done this, and look for tools to predict death, the best one is a cat called Oscar, who lives in a nursing home, and if he comes and sits on your bed, we've touched on advanced care planning. Now, this is a voluntary process. I love my colleagues dearly, all of them. But I have some colleagues who think everyone should have an advanced care plan that says, I don't want to go to hospital anymore. It's made my life really easy, but it is voluntary. And it is difficult to raise. I've asked 95-year-olds, would you be surprised if you died in the next year? And they go, ah! Of course I would. And I think, really? You know, it's hard to raise these topics. And, you know, someone said earlier, you can't do it in one session. I think in primary care, I love that people in primary care have embraced this. I think you are ideally placed. You have that hopefully longitudinal relationship. By the time they get to me, any discussion I have is not advanced. I added the bit in italics and the brackets. Ideally, yes, it should be advanced. We should be thinking about this when we're middle-aged, young, well, what? But certainly as soon as any diagnosis that is made that has implications for life expectancy and quality of life, we should be thinking about that. Ian mentioned earlier, dementia is a terminal illness. We know that the average life expectancy, give or take, with dementia is about 7 years. That's a long time to do some planning before the person may lose capacity to choose there and then. So, we can still, we have clues, What's all this got to do with polypharmacy, I hear you ask? Well, this is another MIAP case, actually. This is one of the cases I was asked to review. This was a man in residential care. It was the staff at the home who'd identified he was on a lot of medication. They had other concerns about his health and well-being. He was referred through to the project. He was seen by a pharmacist, and then I was asked to go and see him as well. And before you ask, yes, it took time. He's only relatively young, chronologically. Biologically, perhaps not so young. A 61-year-old chap. And one of the concerns was that he had perceived memory loss. So the staff would say that he was quite often seemed quite confused. He's got a significant past medical history. He's had a relatively severe stroke. He's got a catheter. He's got some peptic ulcer disease. He's on the magic vitamin O, almost certainly. He's got a background of vascular risk factors, unsurprisingly. He's been depressed in the past, and he's had a documented history of previous alcohol excess. Now, he is in hospital level care, so quite disabled. He requires 2-person assistance for transfers, personal cares. He is able to independently use an electric wheelchair. This was the bit that endeared me to this guy. He's actually still drinking quite a lot. And he's got this system and this network of visitors, not all his, people visiting other people, who he persuades to bring him alcohol, and they hide it in strategic places around the home. And one of the things that became obvious the more we reviewed this chap was that the periods of perceived memory deficit and confusion were actually probably him being intoxicated. And he gets a bit aggressive and abusive, and he's had a number of falls. So, is he demented? No. He's actually cognitively quite with it. His depression screening is mildly positive. And the key thing he describes is grief and loss. He's lost his fishing boat, his car, his wife, his ability to live alone. He can't walk. He's lost social aspects. Friends visit less when you're in a rest home. He's lost a lot, this guy. He tells me he's got some suicidal ideation at times, but he's never actually acted on it and doesn't have any plans. And the conversation comes round to the medications, and he makes the statement. He doesn't want to keep taking anything unless it actually makes him feel better. I couldn't swallow that. Not a hope. So he's on all these medications. Now this is the discussion bit. So how do you approach this? Somebody be brave. How do you look at this list of medications and say, what are we going to do? There's no right or wrong answers, don't be afraid. I'll tell you what I did afterwards.
Asking, is he aware of any of them that make him feel unwell?
A very good start, yeah. Can he? And it's hard, isn't it? You're taking 24 a day. It might be hard to know which are the ones, but there might well be one that he finds particularly difficult to swallow, one that maybe feels like it gets stuck. It may be that he can say, well, the morning ones make me feel worse than the evening ones, so that's a very good start. Anything else?
Are the 24 tablets that have been prescribed or 24 tablets actually taken?
Well, if you count them up, there isn't 24 now. It's just some of them are more than once a day. So it comes to a minimum of 24 physical pills. Well, he's in a nursing home. He doesn't get a lot of choice, does he? They probably hide them in the bananas.
I'd ask myself what
But
the
it's a
risk
good question,
is,
isn't
sorry,
it? I beg your pardon.
what the risk is if I stopped each and every one of those, and how
Yeah.
big the risk is and how quickly it would occur, to give me an indication of which ones I might cut down first.
Yeah, yeah. Absolutely valid points. Having asked him if he rattled, I took the tack of, let's look at them one at a time, and you tell me if you know what it's for. And then I'll tell you what it's for. I'll tell you whether it's likely to make you feel better. I'll tell you how it might make you feel worse, and then you can decide if you want it. Now again, it takes time. But I sat down and went through every single one. Pick one at random. Okay. Lactol. So he's on it regularly. So what do we want to know? We want to know what his bowel habit's like. And, you know, is it really indicated? Does he know what it's for? Well, as it happens with that one, he did. He knew it was for his bowels. He had issues with constipation. And we talked about potential side effects, the fact that if he stopped it, there was a risk he might become constipated. He's relatively immobile, that's a risk factor. And eventually he decided, how about I maybe just try taking one a day instead of 2 a day and see how that goes. The tapering approach, but initiated by the patient in that instance, very sensible. The statin, we've got to talk about the statin because everyone always wants to know about statin. One of the emails was about statin. Now again, bearing in mind evidence, opinion, experience. He's 61. Now increasingly the evidence for statins in older people is just more and more and more confusing. You know, there's no doubt that the side effects are significant and underreported. There's a lot of doubt as to the benefits. There's even increasing confusion about whether high cholesterol is even a significant risk factor the older you get. So if it's not a big risk factor, does it need treating? Does it make you feel better? No, not one single person I've ever met says a statin makes them feel better. So we talked about that. We talked about the fact this is a purely preventative medication. It lowers some numbers on a blood test that you only know about if you have a blood test. So ultimately he chose to stop it. Now the question was raised, we as prescribers can be anxious about that. You know, what if he has a stroke next week? Well, who can tell me, if you've had a stroke, what's the risk of having another? It's about 1 in 20, so 5%. Yeah, 1 in 20. That means 19 out of 20 people don't. All these things we do to people to reduce the risk of another stroke are all relative. And if you look at the absolute risk reduction, it's not that fantastic. So, yeah, all right, he might have a stroke next week, but at least he's made an informed choice. And he knows that the likelihood is that he's more likely not to have a stroke next week than to have one. That's the simple stats. So, you know, working through these things and talking to this guy, did anyone want to comment particularly on any of the other?
Would be the same conversation?
Absolutely, yeah. The relative risk reduction of aspirin in stroke prevention is about 18%, which sounds great, but it's 18% of 5%. So it's all...
It's also 150 milligrams a day, so it's not the enteric-coated one.
There's absolutely no evidence to support the use of enteric-coated aspirin. There's no evidence that it reduces gastrointestinal harm whatsoever.
It's interesting with the method. I've seen described that method as the brown bag test. You go with your brown bag of medicines and you're using the concept of patient literacy. And rather than talk back of what you just told them, they're doing a talk back of all the doctors and health professionals they've ever seen and told them.
Oh, yeah,
And then you see the rubber hits the road the brown bag comes out and they think they're taking it for something completely different. And surprise, surprise, they're not getting the benefit they thought because it didn't have a hope of doing it in the first place. So then you're making a decision between you about whether it's actually indicated for that person.
Shared decision making. You've also just reminded me, if you remember nothing else of what I said today, and that's entirely possible, I want you to remember this one thing. And you all may be very good and not do this. The thing that frustrates me the most is when I say to a patient, I don't think you need to be on this tablet anymore, after a discussion. And their response is, but my doctor told me I'd be on it for life. Do not say that. Never say that. You know, who knows when you put on a tablet at 40 what your life is going to be like at 50, 60, 70, 80, 90, 100, 110. Something's obviously going well if you get into those ages, but you know, warfarin is a classic one, or anticoagulants. People get put on warfarin and told you'll be on it forever, and then they have a massive bleed. And I come along and say, I don't think you should be on that anymore. Oh, but I was told I'd be on it forever. So what I say to people when I start medications, and I don't just stop them, I say to them, at the moment, from the discussions we've had, the benefits of being on this tablet appear to outweigh the risks. I would suggest you take it indefinitely, but a time may come in the future when things change and it becomes appropriate to stop it. So we're giving people that heads up, they may not be on it forever. So that's my handy tip. So, this is what I got him down to afterwards. Now, there are medications on there that I would really rather he was not on. Zopiclone, okay? I went to a wonderful lecture a couple of years ago by a Canadian geriatrician who'd done a lot of research into the drugs beginning with Z, Zopiclone, Zopidermal. Can anyone tell me, if people take these medications, how much extra sleep do they get? It's 15. The average is they get 15 extra minutes of sleep. And the downside to that is they feel hungover, they're drowsy in the morning, they're at risk of falling, they're at risk of tolerance, they're at risk of addiction. I absolutely agree with Marion's comment. When you've got people firmly established on the Z drugs, and in this case alprazolam, getting them off it is very, very hard. And kudos to those of you that try and succeed. I too have largely given up. It is just too hard. My message around that is, don't start them. You know, patients in hospital say to me, can I have a sleeping tablet? And I say, no. Oh, but I'm not sleeping. And I say, no, and you won't sleep with a sleeping tablet, but you might feel worse. And then we have a discussion about the fact that they don't work very well, the fact that they're addictive, they cause side effects, etc., etc. We talk about alternatives. Do you know what the commonest reason I think, I can't quote your research on this, but in hospital, people will say to me, oh, I didn't sleep very well last night. And what do you think the issue actually is? All those things, but do you know what it is? I said to them, what time did you go to bed? It's usually about 7:30. Did you go to bed at 7:30 at home? Like, no. I said, well, you're not going to sleep from 7:30 to 7:30 if that's not what you usually do. Hospitals are boring places, you know, so people go to bed early and they think they should go to sleep. Did anyone want to comment about this gentleman? Has anyone had similar experiences? Or please do chip in, because otherwise this afternoon is going to be really boring because there are no slides then.
Did you talk about his self-administered medicine?
You mean?
The alcohol.
Oh yes, good point. Yes, I did. And I mean, I talked to him about the fact that alcohol can and perhaps should be treated as a drug. And we talked about, you know, why he was drinking. And he did not wish to stop drinking. And given his quality of life, I didn't feel it was appropriate for me to tell him he had to. And so he did agree to having a more structured approach and to not hiding the alcohol and to allowing the nurses to monitor his intake. And reportedly that did go very well. Very good question, thank you for reminding me.
That was a false risk with alcohol plus all of that.
It's a choice. He's an adult. He's competent.
So
It's
okay
legal.
for him to fall.
It's his choice.
Do you have any comments on the therapeutic use of alcohol, you know, for cardiovascular benefit? You know, it's always been touted that red wine in a certain dose is okay. Do you have any thoughts about that?
Well, after that lovely Pinot Noir we had last night. I mean, I have some awareness of the literature. I think it's still quite controversial and confusing. I can give you my opinion, but it's probably not a medically valid opinion. I think that legislation is the wrong word. Advice around recommended levels of alcohol, as I understand it, has very little evidence basis. I think there are large genetic and other differences between different people's abilities to metabolise alcohol. I don't routinely recommend that people take alcohol. When I was first qualified, we used to be able to prescribe tons of alcohol in hospital, and I don't know if that was a risk or a benefit. But yeah, it's a naughty one. So, just a little after story about this man. So, you know, he was quite happy with the changes that were going on. The reports I received afterwards from having communicated with the rest home staff and the GP were that things were going well. He then unfortunately developed or caught a community-acquired pneumonia, was admitted to hospital, and one of my general physician colleagues, bless him, restarted everything that had been stopped, which is where the volume-based medicine came in, as I went round and said, stop it! But we won in the end. So, this is an ongoing case, so there isn't an end to this one yet. This is still happening. This is an 83-year-old lady, again very typical of the patients that you all see and I see. She's got multiple comorbidities, vascular risk factors, arthritis, glaucoma. She lives at home. She does have a package of care for personal cares and some domestic tasks, but she's, you know, compared to a lot of the patients I see, she's relatively independent. She's managing her own medication, so she is able to, you know what she's taking and when she's taking it, and largely takes them very well, and is that awful term that we use, compliant. But she's concerned because, you know, despite being on all these pills, she still feels unwell a lot of the time, you know. Some of it's non-specific, but she's a bit dizzy, she's nauseated, she's got aches and pains. And one thing I'm sure you see, as I do in the elderly, is they put up with an awful lot of aches and pains that I certainly wouldn't. And they just think it's normal to ache and pain. So you do have to specifically ask, you know, they often don't volunteer it. This is her medication list. She's on a lot of pills as well. And that's, you know, again, do you rattle? It's a fairly nightmare list, isn't it? And again, where do we start? All the approaches you've mentioned are valid. You know, does she know what they're for? You know, what are her goals? Is it, you know, what are her fears? What does she want? Is, you know, is the fear of having a stroke or a heart attack greater than the fact that she's probably getting muscle aches and pains from the statin? So every patient is different, and the classic example I always use in this regard is people who are hypertensive but have postural hypotension. Most people have no symptoms when they're hypertensive. They feel dreadful when they have postural hypotension. We get excited by hypertension because we know it's a risk factor for all these horrible things. 99 times out of 100, I'll have a conversation with a patient and say, would you rather accept that you've got a high blood pressure with some risk, and we talk about what the risks are, but not be on these medications that make you dizzy when you stand up? They'll say, stop the pills. Every now and again, there'll be one who says, my fear of having a stroke or a heart attack is so great, I will put up with the dizziness. And then I leave them on it. And I think that's about, you know, informed choice, isn't it? And so we do have to communicate, we do have to establish what people's goals are. This lady's main goal was really just to feel better. And so again, we went through a process of going through all these various medications. This is phase 1, you know. There's still work to do, but we got rid of a few. So again, you don't have to do it all at once. You can reduce things, taper things, stop one week, stop another week. Yes, it's time consuming. Yes, the pharmacists, if you have that resource, are incredibly helpful. Yeah, so, you know, again, this is an absolutely current example. I am seeing her next week. So, yeah. That's pretty much the end of my slides, I think. It's more... Oh, I do have one other slide. This has already been touched on. Somebody told me recently they thought I'd invented this term. I didn't. I wish I had. But no, it has been around a while, and it is a key area. More research is being done. There hasn't been a lot historically, but there's more and more and more. And again, the bit in italics, I think, is the important bit. Where possible, it should be done with input from and consent of the patient and the carers, and you go through each medication one at a time. And, you know, each time I say to them, you know, this is aspirin, it's not going to make you feel better. Studies show it reduces your risk of having a stroke by this much, but your risk is already low. Do you want it? And sometimes they want to think about it, and sometimes they'll say to me, can I discuss it with my GP? And I say, of course you can. So that's where we're at. We do have about 2 minutes, I think, but...
Both of those patients were on amitrip 25. That would have been one of the ones that would have jumped out at me.
Oh, absolutely. Yeah. So, again, I don't need to tell you, but amitriptyline has 2 purposes. It's used for depression. It's considered old-fashioned in these days, but actually it's still very good. And it's used for neurogenic pain. It's often inappropriately used as a sleeping tablet. The 25 milligrams is really, it's too low to be an antidepressant dose, and for an elderly lady it's a bit high if it's a neurogenic pain dose. So I would certainly be looking to try and reduce that and hopefully stop it if possible.
But did they feel they were getting some benefit from it?
Hard to say, isn't it? As we were saying before, when you're taking that many pills, it's often hard to know. So, you know,
But I'm thinking in that discussion, you'd have asked them, you know, did you feel benefit from this? Well, I don't know.
Absolutely.
But I can tell you what it might also be doing adversely for you.
Exactly.
So that's why I'm wondering why they weren't reduced. Or
again, you know, you don't have to do everything at once, and you know, I try and listen to the patient and see what their concerns are and focus. You know, she said aches and pains, so my statin. Yeah, so you try and focus on the ones that you think are causing the immediate issues, and then you can always come back to the others. In hospital, sometimes if I have the luxury of having someone be an inpatient, I have occasionally been brave and stopped everything and started again. But you know, in a community setting, I would be a little bit more wary of doing that.
My boss used to call that a drug holiday.
Yeah.
When I communicate that to some people, they think a holiday, a drug holiday is when you go on holiday and take lots of drugs.
I like that. I was once stoned in Morocco, but not in a good way. I had rocks thrown at
me. Do you think there's any role of, like, with gabapentin in their patients? I mean, pain is a subjective issue.
Of course.
of actually giving a placebo gabapentin and then doing your pain scores later, because I mean, that's a relatively objective way.
It's a very good question. Not with gabapentin, but I have in the past used placebos with inpatients, and it is amazing how uncomfortable a lot of people are with that. And I've had colleagues tell me that they think that what I'm doing is completely unethical. And you know, but there are occasions when I think it does have a validity, and I think, and I've always disclosed to the patient after the event that that's what has happened. And you know, I've been able to help some people come off medications doing that.
There was an article on the ethical use of placebos by the British Medical Journal, and so I mean, they definitely have a role.
Yeah.
But
Yeah.
There's the N of 1 trials where you can, I haven't heard them done very often, but pharmacists can help set up what's called an N of 1 trial, so they blind with the patient's consent at the start, so they blind a period of no drug or a placebo drug and then the active drug, and then they do a monitoring and unblind it at the end.
I had a patient one time with Parkinson's disease who was on a medication that I was convinced was causing an adverse effect, and he didn't believe it was, and we actually took that approach that over a period of a few days he was given a regime of medication, some of which were placebo, some of which weren't. He knew that some of them were going to be placebo, but obviously not which ones. And he came back with a diary of when he had adverse effects and when he didn't, and it matched perfectly with when he got the active drug. And that to him, in actual fact, he was someone with a bit of a mathematical bent. That to him, the figures were enough to convince him to come off that medication. I always ask patients to bring their medications and not just a list, but ideally if they can their actual medications to clinic. And one thing I do, unless there's a really good sensitive reason not to, I always send patients a copy of my clinic letter. So everything that the GP reads, the patient reads. And then, that for them is a check that if they haven't remembered to bring their tablets to the clinic, they can go home and go through the list on the letter and see that it's the same. It costs a stamp and an envelope and a piece of paper.